So hello and a very warm welcome to this discussion-based podcast on key concepts in liver disease. My name's Ed Wallet.
And my name's Rashmi Patel.
And in this podcast, we're going to be introducing some key concepts for understanding liver disease. Specifically, we're going to be talking about two common presentations of liver disease, that is acute liver disease and chronic liver disease. We're going to be talking about how these present, the different clinical features, how you can relate the physiology to the pathology, and then we're also going to be looking at the most important causes that result in these various presentations. If you're interested, there's another podcast that I've done previously on the site on this topic of acute chronic liver disease, and that's called Liver Disease 1, very creative sort of title. So let's start by talking about some very sort of basic liver histology and simplified microanatomy that enables you to really understand what's happening at the sort of histological level with liver pathology and to relate some of the diseases we're going to be talking about to some of the clinical features. So the first thing to say, in the basic structure of the liver, your key cell is your hepatocyte. Just like in other organs, you've got really key cells which perform key functions. In the liver, your key thing is a hepatocyte. This is embedded within a complex connecting network of cords and plates, and it's surrounded by a sort of spongy vascular network which is called vascular sinusoids. Now, it's important to be aware that these vascular sinusoids are composed of blood coming in through both the hepatic portal vein, coming from the gut, bringing blood, nutrients, things that have been absorbed in the gut to the liver, and also from the arterial system in the form of the hepatic artery. And these vascular sinusoids, as they pass through, as the blood passes through, they go through the hepatocytes, around the hepatocytes, and eventually drain into the central vein, which eventually forms together to form the three hepatic veins, which form the output of the liver.
So there's the two inputs, both the hepatic artery and the portal vein.
One output. In terms of key cell types, we've already spoken about one of them. That's the liver cells, the hepatocytes. Important other ones to be aware of are, first of all, the Kupffer cells. These are macrophages, basically, of the liver that are found on sinusoidal endothelium. And the other cell, which is really important in certain pathologies, which we'll talk about later, is the stellate cell. Stellate cell is found in a sort of subendothelial space that has the histological name of the space of Dissay. But the important thing about the stellate cells is that in the context of repeated injury, they can form myofibroblasts and can produce collagen and different things that can predispose to fibrosis. So this stellate cell is very important in the pathology of fibrosis and eventually cirrhosis.
Okay, so that was a very useful overview of the cellular architecture of the liver. Now moving on to liver function. And it's useful to have an idea of the normal liver function and how, where this is affected, this leads to disease. So what are the main functions of the liver? Well, I guess one of the main functions is to remove toxins, whether that be from metabolites or external sources of toxins. And the liver has hepatocytes have a variety of different enzymes which are able to alter molecules to convert them into forms which are excretable. And this is important because failure to do this can lead to encephalopathy. As these toxins build up, they can affect the functioning of the brain, and it can also lead to cerebral edema. In addition to the detoxification functions of the liver, other major functions include those which are related to metabolism, in particular carbohydrate metabolism and glycogen storage, which allows a small supply of carbohydrate to be stored within the liver, and anything which affects this may lead to hypoglycemia. Now moving on to the protein synthesis functions of the liver. And there are two main areas here. The first are the clotting factors, and these are the plasma proteins which are involved in the clotting cascade. and if the synthetic function of the liver is affected and the liver is unable to produce these clotting factors, this can lead to coagulopathy and bleeding, and this can be a major consequence of chronic liver disease. In addition to the clotting factors, there are also several immunological mediators, particularly the acute phase proteins, for which the liver is responsible for their production. And again, if the synthesis of these is affected, it can predispose towards infection. And finally, the other thing to be aware of is the way that the liver functions in relation to the other organ systems of the body. And if liver function is affected, it can have a direct impact on some of the other organ systems, including the kidney and lungs as well.
And this leads to some of the most sort of serious complications of acute liver failure, such as hepatorenal syndrome and indeed hepatopulmonary syndrome. So let's move on now to talk about some key concepts of hepatic failure. So first of all, when we talk about hepatic failure, what we mean is a clinical syndrome when greater than 90% of the functional capacity of the liver is lost. Now, we can broadly consider two types, or traditionally two types of hepatic failure or liver disease have been thought of. These are acute hepatic failure and chronic hepatic failure. What I want to try and explain now is how chronic hepatic failure is not really a sort of correct terminology. It's much better to say chronic liver disease and reserve hepatic failure for acute episodes. So in the acute episode, or what we might call hepatic failure, you can have two types of failure going on. You can have a real acute hepatic failure where there's some massive damage to the liver, say because of a paracetamol overdose, or say because of a fulminant viral infection perhaps of the liver. Yeah. Or, and this is perhaps the most common reason patients get hepatic failure, is because of decompensation of chronic disease or chronic liver disease. So patients with chronic liver disease basically get an intercurrent illness, perhaps related to that. So for example, if they had varices, they might have had a massive GI bleed. Because they have reduced levels of immunoglobulins, they may become septic, or perhaps they might be exposed to various drugs. And all that this really does is it pushes them over the edge, and they lose that final bit of capacity, which results in hepatic failure. And this is often the modality of death in patients with chronic liver disease. So the key point really here is that decompensated liver disease is not the same as chronic liver disease. Yeah. Decompensated liver disease is acute failure in the presence of chronic liver disease.
An acute on chronic.
Acute on chronic picture. Yeah. So often one thing that is described in relation to acute failure is what we might call hepatitis. And what I want to do really is differentiate hepatitis to acute liver failure. So in hepatitis, you basically have liver inflammation that is usually self-limiting. And the most important causes of that are viruses such as hepatitis A, B, C, other viruses such as Epstein-Barr virus, cytomegalovirus are also implicated. And importantly, drugs, particularly drugs taken in overdose, such as paracetamol. On the other hand, you've got liver failure, which is a much more catastrophic insult and represents failure of function of the liver when 90% is lost. And this is very, very severe. And the causes here, as we said, are most commonly decompensation of chronic liver disease, so acute on chronic liver disease, and very occasionally you can get, for any of the causes of hepatitis, you can get what's called a fulminant hepatitis, which is acute liver failure in association with hepatitis.
So that would have to take it beyond the 90%, which... Yeah.
Exactly, the 90% function. So how do you differentiate a simple hepatitis, which you might see in, say, a patient coming back from abroad with a hepatitis A, from a real acute liver failure, dire situation for a patient? Basically, we can talk about clinical features here, so symptoms and signs. Hepatitis, basically, patients feel very, very unwell. They have constitutional symptoms, fever, anorexia, malaise, nausea, usually in association with sort of mild right upper quadrant pain, liver pain. Signs that they might be jaundice, so they might have hyperbilirubinemia. This might manifest in the skin, sclera, or mucous membranes, and they might have tender hepatomegaly. Don't be confused by their LFTs. When you look at the LFTs of these patients, they may be severely deranged. Yes. They may have an ALT up in the 1,000 It doesn't necessarily mean that they have acute liver failure. There are other indices that we use to look at acute liver failure. So in acute liver failure, basically, the key features Rashmi's basically already spoken about when we talked about the normal function of the liver. So if you lose the ability to detoxify because of liver failure, you end up with the buildup of unwanted metabolites, such as various ammonium compounds. The most important complication of this is hepatic encephalopathy. Now, there's lots of grading systems for hepatic encephalopathy. The one that's usually used grades it from 0, which is normal, up to grade 4, which is coma. But lots of states exist in between this, varying from irritability, sleep cycle disturbance is a very early sign of hepatic encephalopathy, right through to disorientation, stupor, and coma. The next thing is jaundice. Now, this you might be quite surprised by this, because you'd expect that, or you might think that lots of patients are out there with chronic liver disease who are actually jaundiced. But what you will probably see if you look at that population is actually most patients on a day-to-day basis actually aren't particularly jaundiced. It's when they develop an acute hepatic failure that they actually become jaundiced. And usually that jaundice, of course, because it's hepatic, is a conjugated jaundice. They also lose the ability to produce clotting factors, so they get a coagulopathy. And this is very, very important because it can lead to bleeding and can worsen things such as varices. And the key biochemical picture here will be that of a raised INR. Obviously, patients are more predisposed to infection. Sepsis, multi-organ failure are often the causes of death in these patients with acute liver failure. And then finally, they can present with these disorders of homeostasis, hepatorenal syndrome and hepatopulmonary syndrome as well.
Okay, now moving on to chronic liver disease. This is persistent liver damage, and this has to be over a long period, over more than 6 months, without any resolution. Now, there's two processes which can happen. First of all is the initial fibrosis, fibrotic process. However, if that persists, whatever the underlying cause is, that can lead to an irreversible cirrhosis. And it is when you have that irreversible damage that you actually begin to impact on the function of the liver. And if that gets to a point where you exceed the capacity of the liver to perform its normal functions, it will lead to a decompensated hepatic failure. So this is this acute on chronic picture. So what is the process going on in cirrhosis? Well, first of all, it's the initial fibrosis which occurs within the tissues of the liver. And at the same time as this happens, the liver attempts to regenerate and has a great capacity to regenerate. You'll see nodules of regenerating hepatocytes within the fibrotic area. However, if this process continues, then the underlying architecture of the liver, which Ed discussed earlier with the triads of the hepatocytes surrounded by the arteries, the portal veins draining into the central veins, if that is disrupted, then it will affect the function of the liver, because this architecture is necessary in order to allow the normal flow of metabolites through the liver. With all three of these present, you end up with irreversible damage to the underlying structure of the liver, and this leads to cirrhosis. Now, the stellate cells are particularly important in this process, and they are involved in the remodeling which occurs, and they produce collagen, which is the substrate for the fibrotic process within the liver. Now, what are the complications of cirrhosis? So, as we've said earlier, this is a chronic process. Now, one of them, as Ed has already mentioned, is the hepatic failure, the decompensated hepatic failure, which can occur in someone who has already got chronic liver disease, but ends up having some kind of other insult, whether it be an infection or other cause, which pushes their liver beyond its capacity to actually function, and that causes this decompensated liver failure. Other complications include hepatocellular carcinoma, and that is because of the cellular damage which occurs owing to the cirrhotic process, making it more likely for the cells to undergo malignant transformation. Another problem which can occur with cirrhosis is because of the disruption of the normal architecture of the liver and the flow of the blood from the portal system back into the systemic system. As that is disrupted, you can end up with portal hypertension, and that's an increased pressure in the portal venous system, which drains the gut to the liver. And this can result in ascites because of the increased hydrostatic pressure within the gut, and can also affect the sites of portosystemic anastomosis. And these are areas where the portal system anastomoses with the systemic venous system. There are three main areas where this occurs: in the lower esophagus, in the rectum, and also around the umbilicus. And in these areas, if portal hypertension occurs, it can affect the veins in these areas, leading to esophageal varices, hemorrhoids, or caproot medusae, which are the dilated veins around the umbilicus, which you can see in patients who've got chronic liver disease. In addition to this, the spleen can be affected owing to the portal hypertension. This can result in splenomegaly. Now, there are several ways of classifying cirrhosis. Traditionally, you might look at the nodules within the liver, and this would be a histological classification according to the size of the nodules. But that actually doesn't correlate that well with how the disease process affects the patient clinically. And now we would consider classifying cirrhosis according to the underlying cause, and that, of course, is key concept in medicine in terms of trying to work out the best management for the patient.
Yeah, absolutely.
So this is a table which breaks down the common causes and the more rare causes of chronic liver disease. Obviously, one of the most common causes is alcohol. And other important causes include fatty liver change, steatohepatitis, and also chronic infection with certain viruses which cause hepatitis, including hepatitis C and hepatitis B. Other less common causes include autoimmune causes, primary biliary cirrhosis, and then rarer inherited causes. And we'll go into these in further detail now.
Yeah. So basically, in the second half of this podcast, we're going to talk about some of these processes that result in either acute liver disease, chronic liver disease, or indeed decompensation. I think what's really important, and I bang about this in all of the podcasts, is have a system.
Absolutely, yeah.
And for this kind of thing, it's useful to just have a mnemonic in your head of all the different processes that can, or pathological processes that can result in disease. And the one I like to use is Vinter Medic. You'll see this in lots of the podcasts that we've produced, this specific table, and fine if you've got your own one, but it's useful just to have this system to go through in your mind. So let's just go through a couple of the most important causes of liver disease and just make a couple of key points that are important. So first of all, viral hepatitis. People get really, really panicked about viral hepatitis. There are the three major viruses: hepatitis A, B, and C. Hepatitis A is the acute sort of hepatitis. It's the one that's usually passed through a fecal-oral route, usually as a result of dodgy shellfish and things like that. It's the one that causes an acute picture and has no chronicity. So nearly 100% of people recover. There's a very, very small group of people who, for some reason, develop acute hepatic failure or fulminant hepatic failure and can do very poorly, but most people recover completely from an episode of hepatitis A. The ones that people get confused about are hepatitis B and C, which are very similar sort of modes and routes of transmission. Even though these figures are only roughly accurate, this is the way that I like to remember it. Hepatitis B, roughly 80% or more people recover than develop a chronic state. So roughly 80% of people will recover completely from hepatitis B, 20% of people will develop chronicity. In hepatitis C, it's the reverse. So roughly 20% of people will recover and won't keep the virus, and 80% of people will develop chronicity. So try and think of the two roughly in sort of a reverse fashion, and that should help you to remember.
And I guess it would also be worth mentioning that there are very effective vaccines available for hepatitis A and B, but not yet for C. And it's certainly, in terms of hepatitis B, has been of great help in terms of reducing the prevalence and transmission.
Yeah, absolutely. And that has important implications for the incidence of some of the complications, things like hepatocellular carcinoma worldwide and things. And absolutely. So going on now to talk a little bit about alcohol, which is obviously very, very important, very, very important cause of liver disease. Alcohol fundamentally is a hepatotoxin. Therefore, the amount that you take in each day will correspond to the amount of damage that is done to the liver. However, it's useful to be aware that there are actually a number of distinct pathologies that don't necessarily follow each other chronologically that result from alcohol with the liver. One of these is alcohol hepatitis, and this can happen acutely in someone who goes on a massive drinking binge. One of the complications, of course, is pancreatitis, but people can develop an acute hepatitis, very, very similar to that which you might get, say, with acute hepatitis A infection in response to alcohol. In chronic users of alcohol, many of them go on to develop an alcoholic fatty liver, and this is really just a marker of chronic alcohol intake. What it doesn't mean is that those particular group of patients are going to all develop alcoholic cirrhosis. As I said, these things are not a continuum, and we don't really know why. It's possibly due to the exposure, the nature of the exposure, sort of various genetic factors which predispose people to develop alcoholic cirrhosis. But what we do know is that there are distinct entities. That fatty liver can be as a result of alcohol, and cirrhosis can be a complication of long-term alcohol use. And the reason really for this goes back to what Rashmi was talking about with these stellate cells, which are really, really key in producing fibrosis, as we know that alcohol byproducts actually activate these cells. And we've already mentioned that this isn't a continuum necessarily with alcoholic fatty liver or hepatitis.
Okay, and now moving on to non-alcoholic liver disease. This is called steatohepatitis, or fatty change of the liver, but is not caused by alcohol. Although it's similar in terms of appearance, it's associated in particular with the metabolic syndrome and possibly the insulin resistance with reduced peripheral lipolysis. And it's on a continuum with fatty liver disease and steatohepatitis. And as before, there's not necessarily a direct sort of natural history in terms of the processes which occur, and you may get a sort of inflammatory change or this fatty change. And the inflammatory change may lead to cirrhosis, but they're not in exactly in terms of natural history, that order.
Exactly.
Now, a more rare cause of chronic liver disease, but one which everyone remembers for reasons owing to these Kaiser-Fleischerings, which I'll come on to, Wilson's disease. Now, this is a disorder of a particular protein in the liver, the ATPase copper transport protein, and this particular protein is involved in the transport of copper ions inside the hepatocytes and also in other organs as well. And in terms of the liver, this causes an accumulation of copper, leading to this particular histological appearance of hepatolenticular degeneration. However, this enzyme is also affected in other organ systems, in particular the central nervous system and the eyes, and this gives rise to the particular Kaiser-Fleischer rings, which everyone learns about.
And I still don't know. I still don't know what one looks like.
Yeah, I've never seen one, but it's in the textbooks. It's autosomal dominant transmission, and in diagnosing these patients, you need to measure the levels of copper and ceruloplasmin, which is a copper-binding protein, and usually, but not always, both of these will be low.
Yeah.
Now, moving on to hemochromatosis. This is caused also by an accumulation of an ion, in in this case the iron, and is caused by a mutation in the HFE gene, which is part of the in the major histocompatibility complex. Now, it usually manifests in the elderly because it takes time for the iron to accumulate over a number of years. And again, as for Wilson's disease, it's not just the liver which is affected, but also the pancreas, the heart, the joints, the pituitary, the gonads, and all of these organs will as they get infiltrated with iron, you'll get a particular clinical picture of the liver cirrhosis and the diabetes, as well as heart failure and arthritis. And typically what you might see initially is you might find someone who's got signs of chronic liver disease. They may also have dark brown pigmentation. They may have impaired glucose tolerance. And these findings might lead you to go on to investigate further to see if they have this particular mutation.
Yeah, I mean, it should be said that those are probably the key two organs, aren't they? The liver
yeah,
and the pancreas.
The liver and the pancreas.
And that's why this is often actually called bronze diabetes.
That's right, exactly, yeah.
So the last couple of conditions, just briefly to mention this one, which is alpha-1 antitrypsin deficiency. This is one of the key causes of pan-acinar emphysema because of the loss of key antiproteases within the lungs, but it's also useful to bear in mind that this also can lead to cirrhosis as well because of a similar loss of antiproteases, the alpha-1 antitrypsin. However, the last three conditions I want to talk about are sort of autoimmune conditions, mainly autoimmune hepatitis, primary sclerosing cholangitis, and primary biliary cirrhosis. Not to talk in detail about them, but just to mention the sort of key features that you should look for in a patient and a question in your exams. So autoimmune hepatitis is exactly as it said. There's an autoimmune attack directed against the liver. Now, this is usually following some sort of trivial infection, often preceding it. And this is all to do with concepts in autoimmunity to do with molecular mimicry with various bacteria, viruses, etc. The features are typically of a middle-aged woman who often actually has coexistent autoimmune disease, so might also suffer from, say, type 1 diabetes, or may have perhaps thyroid dysfunction or
so often they tend to be associated with each other.
Autoimmune diseases tend to coalesce together. And the characteristic features here are high transaminases. So as you'd expect, hepatitis, you're looking at a raised ALT, AST, the transaminases, rather than the ALP gamma GT. You also get this characteristic raised IgG with autoimmune hepatitis. Now, there's lots of autoantibodies with all of these conditions, but there are a couple of ones that you should really, really try and remember. And in autoimmune hepatitis, you should remember ANA and anti-smooth muscle antibodies. Those are the key ones. And in terms of treatment, there are different types of autoimmune hepatitis, but as a general rule, most cases respond fairly well to steroids. In terms of these other two conditions, primary biliary cirrhosis is where you basically have intrahepatic bile ducts affected, the cholangiocytes, and these cells get attacked by the immune system, and this leads to progressive cirrhosis. Contrast this to primary sclerosing cholangitis, where you get sclerosis both of the intra and extrahepatic ducts. Importantly, with primary sclerosing cholangitis, this is really, really heavily associated with ulcerative colitis. Up to 75% of cases of primary sclerosing cholangitis have coexistent ulcerative colitis. And the way to detect it, as you might expect, because of the involvement of the hepatic ducts, intra and extrahepatic ducts, is a raised ALP, so it's an obstructive type picture. While in primary biliary cirrhosis, you'll have ALP and gamma GT. But interestingly, with this condition, because it's quite slowly progressive, patients often present simply with pruritus. That's often the only feature they present with. In terms of the key autoantibodies for primary biliary cirrhosis, the one you need to remember is anti-mitochondrial antibodies. So that's it. In this podcast, we've looked at some basic liver structure, some histology. We've related how the function of the liver is affected with liver disease, resulting in various consequences. And then we've looked at the key manifestations of liver disease. Chronic liver disease, which can be due to various pathologies, together with acute liver disease, which can either be a hepatitis, can be an acute fulminant hepatitis, or most commonly can be a decompensation of a chronic process. So that's it. Thanks very much for listening.
Yep, thank you.
And we'll see you soon.